Hello, good evening, everyone. Good evening, everyone. Can we hear me, please? Hello, good evening. Can we hear me, please? I would like to get our feedback if you can hear me.
Good evening.
Oh, good evening. Am I clear at your end? Can you hear me clearly?
Yes.
Oh, beautiful.
Yes, sure.
Okay, good evening, everyone.
Good evening.
Welcome to today's class. Trying to share my slide now. Give me a few minutes or few moments. Okay, share. Trying to share my slide so that we can all have access to it. Coming trying to share my screen, please. I'm so sorry, I'm trying to share my screen so that we can all see it. I need a moment, please. Sorry. I do apologize. Yes, can we see my screen?
Yes.
Okay. Good evening, everyone. Okay. Well, welcome to today's class. This evening, we'll be talking about the endocrine disorders, that is the problems or the issues or the disorders that could happen with the endocrine system. But before we dive into the class, I would like us to take a brief introduction or just a refreshment of what the endocrine system is. That means the anatomy of the endocrine system, because you have to actually understand the anatomy of the endocrine system before we can get ourselves used to the disorders that are possible with the endocrine system. So basically, the endocrine system, just taking a brief anatomy now, the endocrine system consists of organs or consists of glands that helps to secrete hormones that the body needs in order to function properly. These hormones are very vital in maintaining the internal body environment, as well as producing hormones that the body needs in development, such as in growth, in reproduction, and even in rejuvenating of cells. So basically, the body comprises of several glands, but for NCLEX purpose, we are going to be dealing with these glands majorly. The first one is the hypothalamus gland, followed by the pituitary gland. As you can see on the diagram, you have both the hypothalamus, the pineal body, and the pituitary gland located in the CNS. That's the central nervous system. Then moving from there to the neck region, we have the thyroid gland. A little bit away from the thyroid gland, we have the thymus. Close to the thymus too, we have the parathyroid glands too. Just a little bit below the thyroid, you have the parathyroid glands. Then moving further, we have the pancreas. We have on top of the kidneys, on top of the two kidneys, we have the adrenal glands. Then from there, we have the gonads. The gonads are basically the male testes and the female ovaries. They're basically the ones that has to do with the reproductive system. So by way of introduction, sorry, please, I need to... Okay, so by way of introduction, the endocrine system is a network of glands that helps to secrete hormones. And these hormones act as chemical messengers to regulate various body functions. They help to regulate various different functionings, including for growth, for metabolism, for reproduction, as well as our responses to stress. They help the body in adapting to stress, in maintaining metabolism, in helping reproduction. We'll be referring to the gonad in that aspect. So what are the types of endocrine glands? Basically, we have shown us, or I have shown you the location of these endocrine glands. We said basically we have the hypothalamus and the pituitary gland, both located in the what? In the CNS, that's the central nervous system. You have the thyroid gland and the parathyroid gland. You have the adrenal gland, we have the pancreas, and we have the gonads. So we're going to be taking this one after the other. But before then, let's dive into the risk factors for endocrine problems. Recall our focus here is endocrine disorders or problems of the endocrine system. But we just have to do a little bit of anatomy in order to refresh our memory so that we can know when the body is actually deviating from normal. So what are the possible risk factors for endocrine problem? The first thing is age. Like we've always said, like when we talked about in our previous class, when we talked about metabolism and things like that, we basically say even the oncology class, we said for all factors, just have it in mind that there is always a modifiable factor and a non-modifying factor. The modifiable factors are the factors humans, we have influence on it, like we have the ability to change or to reduce their occurrence. But for non-modifiable factors, there are those factors that naturally there is nothing we can do about it. Like they occur based on what? Based on the genetic predisposition or the genetic makeup, how we are made, how our gene determine it. That is the non-modifiable. So for risk factors that can cause endocrine disorders. The first one is the modifying factors. Example under the modifying factors, you have age, you have trauma and environmental factors. While others non-modifiable factors will be that of the congenital factors and the consequences of other health problems or surgery and hereditary. These are basically the factors that can affect it. Now let's take those glands one after the other. Hypothalamus. Hypothalamus is the portion of the encephalons of the brain, forming floor or part of the lateral walls. So there are portions of the diencephalons of the brain. They form the floor or part of the lateral wall of the third ventricle. What they function basically by activating and controlling the peripheral autonomic nervous system. That means they control all the activities of the peripheral autonomic system. Endocrine processes, they are the main and the major gland that help to control all other endocrine glands. Like they are the major one, they kind of control every other activities of the endocrine processes. And many somatic functions too, such as body temperature. They also help in regulating body temperature, sleep, and appetite. Recall we said that basically they help to control the integral of the peripheral autonomic system, as well as they are the core, excuse me, please. They are the core controller of every other endocrine processes and many somatic functions, such as controlling of body temperature, sleep, and appetite. Now, the pituitary gland, these are known as the master gland or mastery gland. They are located at the base of the brain. They are influenced by the hypothalamus. Of course, I said it earlier that the hypothalamus tend to influence some of these glands. So they are influenced by the hypothalamus. So anything that has to do with the hypothalamus automatically affects the pituitary gland. So they directly affect the function of other endocrine glands too. They help to promote growth of body tissues, influence water reabsorption by the kidney, and control sexual development and function. When we talked about fluid volume excess in our previous class, when we talked about fluid and electrolytes, recall we said something about kidney helping in reabsorption of water. So if there's a miscommunication between the pituitary gland and the renal system, it will lead to inability of the renal system in absorbing water, leading to what? Leading to dehydration, or depending on how it affects it, either it's overproducing. If it's overproducing, it will lead to dehydration, but if it is underproduction, it will lead to what? It will lead to excessive water in the body. So that's fluid volume excess. So it helps to promote growth of tissue, influences water reabsorption by the kidney, and control sexual development. Okay, so now let's take the adrenal glands. The adrenal glands there are two in number, one located on each of the kidneys. You recall we have two kidneys, one by the right and the other by the left. So the adrenal glands are directly sitting on top of the kidneys. So they help to regulate sodium and electrolyte balance. They basically help in regulating sodium and electrolyte balance, other electrolytes, but basically their function is to regulate sodium. Now let's take, for example, when there is a defect or a dysfunctioning of this adrenal gland, what happens to sodium? Definitely there will be either hyponatremia or hypernatremia due to inability of the adrenal gland to help regulating the system. So it also affects carbohydrates, fat, metabolism. Sodium, adrenaline glands, that's the adrenal glands, they also help in the metabolism of our carbohydrates, our fats, and our protein when consumed. It also influences the development of sexual characteristics. It's having the same functioning as that of the hypothalamus. It also helps to sustain the fight or flight responses. This is just to say in response to stressor or stress. So basically, the adrenal gland is divided into two portions. We have the adrenal cortex and we have the adrenal medulla. The adrenal cortex is the outer shed of the adrenal gland. That is the outer part of the adrenal gland is the adrenal cortex. And they help to synthesize basically two hormones. Majorly, they synthesize, that means they produce two hormones. The first one is the glucocorticoids and the other one is mineralocorticoids. These hormones are so important. We will talk about this as we move further, especially in metabolism of the carbohydrates. So they also secrete smaller amount of sex hormones. You recall, we said they are needed for sexual functioning too. They secrete small amount of sex hormone, unlike that of the gonads, that is the ovaries and the testes. They secrete minute amounts, which is usually the androgens and the estrogens. So now the adrenal medulla, we're still dividing the adrenal cortex into two. You have the adrenal cortex, which the adrenal gland is divided into two layers. You have the adrenal cortex and the adrenal medulla. The adrenal cortex is the outer layer, while the adrenal medulla is the inner layer. So the medulla is the inner core of the adrenal gland. They work as part of the sympathetic nervous system and produce epinephrine and non-epinephrine epinephrine. We will understand this better as we go ahead. We'll see reason why epinephrine and non-epinephrine is given to patients, especially patients with low who are trying to resuscitate. So now, the thyroid gland is located in the anterior part of the neck, and the thyroid glands are located in the anterior part of the neck. They help to control the rate of body metabolism and growth. The thyroid glands help in controlling the rate of body metabolism and growth. They produce basically the thyroxine, that's T4, and the thyroid 9. T3.
Mariana, umva.
Okay,
We
please, can you mute yourself? I'm sharing my screen. I think I muted everyone earlier, please. Okay, so the thyroid gland basically is located in the anterior part of the neck, and they help to control body metabolism and growth. So this very gland is responsible for the rate at which individual grows. Especially when you remember the call of the gigantism and the dwarfism. Yeah, so we're talking about basically this hormone because they help to set this gland because they help to secrete the thyroxine hormone, right? And the triiodothyronine, that's T3, and thyrocalcitonin hormone. These are basically the 3 hormones that these thyroid glands secrete. So next we have the parathyroid glands. These are located on the thyroid glands. They control calcium and phosphorus metabolism. So for NCLEX tricky question, you can have something like parathyroid issues. Okay, so the next thing you want to look out for this patient is, most likely this client is likely going to come down with either hypercalcemia or hypocalcemia. And in our last class, I gave us two basic indicators for hypocalcemia. I said these are NCLEX trick questions. Like I saw it in my exam. Like it's these two major things, you just have to look out for it. Like we call them the Strovic signs and the Trussell sign, where you have there is paresthesia of the facial muscle and that of the what? The carpal muscle and that of the wrist muscle. Okay, we explained that in our previous class. I'm just citing an example here that anything that has to do with parathyroid gland, any dysfunction of the parathyroid gland definitely affects the level of calcium and phosphorus in the body. Okay, they also help to produce parathyroid hormones. Now, let's talk about the pancreas. The pancreas are located posteriorly to the stomach. That is, you find them behind the stomach. It influences carbohydrate metabolism. Like basically, the function of pancreas is to secrete one of the basic, what's it called now? Hormone, insulin, that the carbohydrates use, right? That the sugar in the body use for its metabolism, okay? So indirectly, it influences fat and protein metabolism. Directly, it is for carbohydrate metabolism, but indirectly, it also influences fat and protein metabolism. It produces the basic hormone that the pancreas produces is the insulin and the glucagons. Now, the gonads. The ovaries are located, basically for gonads, you're talking about the testes and the ovaries. The ovaries are located in the pelvic cavity and produce estrogen and progesterone, while the testes are located in the scrotum that controls the development of secondary sex characteristics and produce testosterone. Now, what are the diagnostic tests? How do we investigate, or how do we know, how do we ascertain, how do we rule out that a client is having or already have endocrine dysfunction? The first one is there's something called stimulation test. This stimulation test is usually done when a client is suspected to have underactivity of endocrine glands. Simply put, when a client is not producing enough hormones by the glands, like the hormones are not being produced, okay? So a stimulus may be provided to determine whether the gland is capable of normal hormone production. Recall, this stimulation is it is done to activate, like something to push the glands that, let's see if you produce or you won't produce. It's like a stimulus. Yes, exactly. That's what it's like, a stimulus to know if the glands are functioning properly. So this helps to measure the amount of selected hormone or substances that are administered to targeting the product of its hormones. Okay, so the next one is then the hormone level produced by the targeted organ are measured. Failure of this hormone level to increase with stimulation indicates hypofunction. As I've said earlier, that stimulation simply implies that it is done when there is a suspicion of hypoproduction or hypofunctioning of the glands. So the hormones are stimulated, and when stimulated, they are being measured. So depending on the level of the measurement is how the disease process or the disorders is being diagnosed. Actually, this is not a nursing procedure, but for knowledge sake, it is included in NCLEX. So the other kind of test is suppression test, and this is just opposite of stimulation. This is suppression, and it has to do with when there's an overproduction of the glands. You know, the first one is stimulation, which is underproduction. While for suppression, there is a suspicion or there are clinical manifestations or signs that a particular client is secreting excessive hormone by the endocrine glands. So suppression normal. Okay. So agents that normally induce a suppressed hormones are administered to determine whether normal negative feedback is intact. Failure of this hormone production to be suppressed during standardized testing indicates hyperfunction. So the next kind of test that is being done to indicate if a client actually have endocrine disorder or endocrine problems is overnight dexamethasone suppression. It's an example of suppression. We talked about earlier and stimulation. So overnight dexamethasone suppression test. This is used to distinguish between Cushing disease or Cushing syndrome and Cushing disease. Cushing disease and Cushing syndrome. We'll talk about this in a jiffy. So in Cushing disease, the source of excess cortisol is the pituitary gland rather than the adrenal cortex or exogenous corticosteroid administration. That means the IV administration of the corticosteroid. That's the exogenous thing. So dexamethasone, a potent long-acting corticosteroid, is given at bedtime and should suppress the morning cortisol in clients without Cushing's disease by suppressing adrenocorticotropic hormone, that's ACTH, production. In the clients with Cushing disease, this suppression will not occur. All these are not nursing procedure. It's just for knowledge sake. So another kind of test we do is radioactive iodine uptake. This thyroid functioning test, this is basically used for thyroid functioning test actually, and it helps to measure the absorption of iodine isotopes to determine how the thyroid gland is functioning. A small dose of radioactive iodine is given by mouth or intravenously. The amount of radioactivity is measured in 2 to 4 hours and again at 24 hours. Normal values are approximately 3% to 10% at 2 to 4 hours and 5% to 30% in 24 hours. Elevated values indicate hypothyroidism, decreased iodine intake, or increased iodine secretion. While decreased value that is less than 3% is less than 3% if done within 2 to 4 hours, or less than 5% if done within 24 hours. So decreased level indicates low T4 level, which simply indicates that that patient is suffering from what? Hypothyroidism. The use of which is usually, this hypothyroidism is usually as a result of antithyroid medication, thyroiditis, and maxedema. We'll talk about that. This test is contraindicated in pregnancy. Please, let's record that this test that we're talking about, that is the radioactive iodine uptake. Recall during our last class when we talked about management of oncology. Under the management of oncology, we basically talked about radiotherapy, and we made mention of 2 types of radiotherapy. We talked about the brachytherapy, which is the one inserted, the one that is usually put in the body cavity where the cancer is or where the cancer developed from, and we have the external one, right? And we talked about the internal one, that even for the external one, you should reduce the exposure of pregnant people. And we said pregnant nurses should never attend to radioactive clients on radiotherapy. And now we're saying that for this particular test, for radioactive iodine uptake, it should never be given to it should never be performed on pregnant women. Why? Because studies have found out that radiation have teratogenic properties that can cause deformity in the developing fetus. So you want to, in as much as possible. So one of the basic nursing responsibility for this kind of procedure, especially if the client happens to be a female, is to check the last menstrual cycle, okay? You ask the client for the last menstrual days, okay? You write it, and then you carry out a pregnancy test to confirm that this patient is not pregnant before this test is done. That is basically one of the nursing responsibility for that procedure. So the next one is T3 and T4 resin uptake test. This is a blood test that I use to diagnose thyroid dysfunction. Okay, same thing, just for thyroid, same as the radioactive isotope 2. It's just a continuation.
Yeah.
So we also have thyroid scan. We also have thyroid scan. Okay, a thyroid scan is performed to identify nodules or growths. To identify nodules or growths in the thyroid glands. A radioisotope of iodine or technetium is administered before scanning the patient. The function of this iodine is just to make a clearer picture of the growth to be assessed. So reassure, one of the basic nurses' role here is to reassure the client that the level of radioactivity medication is not dangerous to self or to others, unlike what we have in radioactive isotope that we talked about earlier. Okay, so determine whether the client has received radiographic contrast agents within the past 3 months, because this may invalidate the scan. So you want to ensure, this is our responsibility too, you want to ensure that this patient or this client have not undergo radiographic contrast. That is the iodine we talked about earlier in the last 3 months, as this may invalidate the scan. Okay, you also want to check that the primary healthcare provider regarding discontinuing medication containing iodine for 14 days before the test, and the need to discontinue thyroid medication before the test. This is our responsibility. You have to ensure that the primary healthcare provider, okay, you want to ensure that the primary healthcare provider has discontinued the medication that contains. Anyway. Hello, Judith. Please, can you share? Hello, you're disturbing the class. Can you mute yourself, please? I did mute everyone earlier. What's going on? Thank you. Okay, so you want to ensure, part of nurses' responsibility is to ensure that the primary healthcare provider has discontinued any drugs that contain iodine. That is why it is very essential for nurses. We have to be conversant with our medications. You have to know the content of medications. Anyone that contains iodine should be ruled out for a patient who is to undergo this scan, this thyroid scan. Okay, I also want to instruct the client to maintain nothing per oral, NPO, nothing per oral status after midnight on the day before the test. Yes, patient should not consume anything at the midnight before the test per oral, please. If iodine is used, that's because the iodine that is administered is just to give a clearer picture of the glands. So when patients consume food, it can bring about showing up, hence patient is at risk for what? Aspiration, or even invalidating the results. So if iodine is used, the client will fast for additional 45 minutes after ingestion of the oral isotope. That is, if iodine is used for this test, patients will need to still wait after the administration for proper absorption of the iodine, and the scan will be performed in 24 hours. If technetium, if technetium is used, it is administered by IV route. So patients will wait 30 minutes before the scan. The test is contraindicated in pregnancy. See, anywhere you see the word iodine, radiation, and technetium, please always note that it is highly contraindicated in pregnancy. Why? Because of the property of teratogenic in this substances. So you want to prevent the fetus from misforming or from malformation. So you also want to do needle aspiration of thyroid tissue. You see, so far we've been discussing majority of this kind of involve thyroid. That's because thyroid issue have to be the one of the most relevant. That is, it's more compared to other endocrine glands. So you also need to do needle aspiration tissue. Okay, so aspiration of thyroid tissue is done for cytological examination. This cytology simply implies for cancerous examination. This is done when there is a suspicion or the primary healthcare provider is suspecting that this client is likely having a CA, that's cancer. So no client preparation is necessary. That's for needle aspiration of thyroid tissue. No client preparation is necessary. NPO, that's nothing per oral status, may or may not be prescribed. Okay, so little pressure is applied to the. So little pressure is applied. Miss Judith, please mute yourself. So little, besides for this procedure. Please. Can you hear me? Hello, can you hear me?
Yes, we are hearing you.
Okay, thank you. So we said little pressure. One of the nurses' responsibility for this procedure, that's needle aspiration of the needle, is just to apply light pressure to the aspiration site after the procedure. You don't rub, you just apply pressure, that's all. Little pressure, please. So the next one is glycosylate hemoglobin. Is another test used to determine the endocrine dysfunction. You have the glycosylate hemoglobin, and this is usually done for clients with diabetic mellitus. So this is basically done for endocrine gland of the what? Of the pancreas. Okay, so we have something called this glycosylate hemoglobin is abbreviated as HGBA1C. HGBA1C. That's the abbreviation for glycosylate hemoglobin. So it's a blood glucose bound to hemoglobin. That's how the blood is being bound to the what? How the blood glucose is being bound to the hemoglobin. It's a reflection of how well blood glucose level have been controlled for the past 3 to 4 months. Please don't be tricked. In NCLEX, they like this question very well. How it has been controlled for the past 3 to 4 months, not immediately, because some questions might come with immediate, the immediate investigation. Like they might give you a case scenario and tell you the client fainted. Before fainting, she complained of dizziness, blah blah blah. What is the immediate test to be done? You might say something of glycosylate hemoglobin. You might say something like needle prick. This how do you call it in your side now? This needle prick that we do to confirm their test, rapid testing. The rapid test you do to confirm the sugar level, they'll give you another one, and they'll give you urinalysis and things like that. Please always know that for glycosylate hemoglobin, it is not an immediate determinant to know if a client have diabetes mellitus. This is done to know how well the sugar level is controlled after 3 to 4 months, not an immediate investigation. Please, let's note that. So hyperglycemia in clients with diabetes is usually a cause of an increase. Exactly. For clients who have hyperglycemia, it's usually a cause of increase in HbA1c. Anyway, you see an increase, most likely the patient is what? Is having hyperglycemia, that's increased sugar level. So fasting is not required before the test. Patient don't need to fast at all. So normal reference range from less than 6%, with is also less than 6% for adults without diabetes. Recall, I said that this type of test, this glycosylate hemoglobin, it is done to rule out what, how the glucose is bound to the hemoglobin. It is not an immediate test to know if a sugar level is high, because it takes a while, like 3 to 4 months, just to know how well someone's sugar is being controlled. Okay, so fasting is not required for this test. Normal reference range between less than 6, it has to be less than 6, that's the normal range without diabetes. But poor glycemic control in a client with diabetes mellitus is usually the cause of an increase. Okay, I think this is a repetition. Okay, so this is what a glycemic index chart looks like. So if it is lower than, let's see, this is normal value. You know, the first value we said was for clients without diabetes. So for clients who have diabetes now, anything less than 55 is considered low, okay? Still okay. Anything medium, 55 to 69, that patient is tinting towards what? Red sign. That is higher GI, that's glycemic index. And when the patient is tinting towards high, the possibility of that person going into diabetic ketoacidosis is high. So you want to always maintain patients and at a lower GI, okay? So this is exactly another representation, blood sugar level chart for, but this is for pregnancy, okay? Because this is also done in pregnancy too. So these are one of the tests that are not contraindicated in pregnancy, unlike all the ones we've been mentioning. So they will have something called the good, the bad, and the very bad glycemic index, just like it is in this. This is the good, this is the medium good, and this is the bad, or this is the moderate. The orange one is the moderate, while the high one is the bad glycemic index. Okay, are we together? Can you hear me, please?
Yes.
Let's continue.
Yes.
Okay, I don't know. I think my slide is not moving. Come in. Let me check on it. Oh, God. I don't know what's going on. Sorry, please. Okay, can still continue, but let me open it on my. I don't know what's going on. The slide refuses to move. It would be nice not seeing this slide.
You had finished.
Sorry? I can't move the slide. Can you see my slide?
Yeah.
How come I'm not seeing it from here? Can you please give me a moment so that let me try and log in back, because like I can't access it. Just I don't know, it's hanging on my at my hand here. Is it fine we start this class back in the next, let's say 2 minutes or 5 minutes, so that I can reboot my system? I don't know, it's hanging. I'm so sorry. Is that okay, please? Let me shut it down and put it up back so that we can all have access to it. I won't display. Are we still together, please?
Yes, we are together.
Can you see my slide?
Yes.
Okay, thank you. But it's still not moving. Okay.
Okay.
So let's talk about, where did we stop? Okay, here, right? Now let's talk about some of the pituitary problems. We have talked about, so far we have talked about the anatomy. We've talked about briefly the anatomy of the endocrine glands. Now let's take the endocrine system one after the other, the problems one after the other. So basically, the anterior pituitary glands help basically have two dysfunctioning with them. Basically two, the anterior part. It could either be as a result of hyperpituitarism or hypopituitarism. Okay, but for the posterior aspect, the problem can be caused by damage to the posterior pituitary or the hypothalamus. So for anterior pituitary gland, this is it. For pituitary gland, there are basically two problems involved. It could either be problems with the anterior region or problems with the posterior region. So anything that has to do with the anterior pituitary gland, so the problem we are going to be either hypopituitarism or hyperpituitarism, okay? But for anything that affects the posterior pituitary glands, the problem are usually diabetes insipidus or SIADH, that is syndrome of inappropriate antidiuretic hormone. So now let's take the hypopituitary glands. Hypopituitarism, that's problem of the anterior pituitary glands, okay? So what is hypopituitary? Hypopituitary simply means that the hypothalamus, sorry, the pituitary glands are not secreting enough. Hypo simply means inappropriate, inadequate, right? So what could be the reason? This could be as a result of tumor, trauma, encephalitis, autoimmunity, or stroke. Hormones most often affected are the growth hormones and the gonadotrophin hormones. Basically, we are saying that these hormones are produced in a what? In a low quantity. And this production could be as a result of what? Either it could be as a result of tumor, trauma, encephalitis, autoimmunity, or even stroke. So, and basically, when these hormones are not, which hormones are not even produced appropriately, it is basically the growth hormone, that's the GH, the gonadotrophin hormones, which helps in producing two other hormones, such as the luteinizing hormone and the follicle stimulating hormone. But please note that the thyroid stimulating hormones, that's the TH and the other, may not be involved in this case now. Okay, so what are the assessments? How do you know a patient is having hypopituitarism? The first thing you will see is mild to moderate obesity. Why? Because the GH, besides the GH is affected, the GH, which is the growth hormone, and the gonadotrophin are the majorly affected hormones here. So there is mild to moderate obesity. There is reduced cardiac output. There's also infertility, because we said the luteinizing hormone is being produced by this particular gland. So there is infertility, there's sexual dysfunction, there could be fatigue or low blood pressure. There could also be tumor of the pituitary. The tumor of the pituitary may also cause headache. That means patient is likely going to come down with headache. So what are the interventions? What do we do? Please note that this assessment for NCLEX purpose, it is the same thing as clinical signs or signs and symptoms that clients present with. But for NCLEX, it is used as assessment. Assessment are those things you see when you observe or when you assess the clients. That's the main reason I left it with assessment, but it's basically the signs and symptoms. So what are the interventions? The first thing to do is just to do hormonal replacement of the hormone for specific deficient hormone, depending on the kind of hormone now that is being reduced in the hypopituitarism deficiency. That's the exact hormone you replace with. You also want to give emotional support to the clients and family. You want to encourage the clients and family to express feelings. You encourage them to express their feeling related to disturbed body image and sexual dysfunction. Of course, this is one of the things that most clients don't like to discuss, especially body image. But you can tell from your assessment that this client is being disturbed. So you have to encourage them to speak out. You educate clients regarding signs and symptoms of hypofunctioning and hyperfunctioning related to insufficient or excess hormone replacement. The moment you are replacing, because hormone replacement, the fact that you want it to help in setting up the hormone that is being deficient, you also want to keep a close watch on the client so that the patient don't move from hypo to hyper due to excessive administration of the hormone. So the next one on my list is hyperpituitarism. So this is hypersecretion of growth hormone. It's just opposite of the hypo. When you have hypo is low, when you have hyper is high. So it's like hypersecretion of the growth hormone by the anterior pituitary gland in an adult. It is also known as acromegaly. That is, you see the adult coming up very big, like gigantic, but for the other one, you see them tiny. They're always small. They look smaller than their age. So the major cause here, the primary cause of hyperpituitarism is what? Is pituitary tumors, majorly because of tumor. So assessment, what are those things? You have patients coming out with very large hand and feet. They have very large hand and feet. There's thickening and protrusion of the jaw. Their jaws are always thick and protruded. There could also be joint pain. There could also be visual disturbance, diaphoresis, that is excessive sweating, oily rough skin, and organomegaly. That is, they have all their body organs in large states, including their spleen. It could also result into hypertension, atherosclerosis, cardiomegaly, heart failure, dysphagia, that's difficulty in swallowing due to the what? Protrusion of their jaw. There could also be deepening of the voice, thickening of the tongue, narrowing of the airway, sleep apnea, hyperglycemia, colon pollens, and increased colon cancer risk. Of course, the major cause is tumor at the what? At the glands. So what do we do? What are the interventions? The first thing you want to do is provide pharmacological intervention to suppress the growth hormone or to block the action of the growth hormone. That is because it's growth hormone that is being produced excessively. So you have to stop its production. You also prepare the client for radiation of the pituitary gland. You want to prepare the client for radiation of the pituitary. Recall, we said the primary cause for this dysfunction, which is what? Hyperparathyroidism, which is what? Primary tumor. That the major cause is tumor. Because it's tumor, you want to radiate that tumor. You want to kill the tumor cells away from the normal cell. Remember in our last class, we differentiated chemotherapy from radiotherapy. We said chemotherapy have the ability of killing both the normal cell and the cancerous cell, while radiotherapy have that ability to differentiate between the normal cell and the cancerous cell. That's why radiotherapy is being used in this case now. So we want to prepare the client for radiation of the pituitary gland or the stereotactic radiosurgery if prescribed. There's a surgery which is the stereotactic radiosurgery, but most of the time it is radiation therapy that is done. Okay, so you also want to prepare the client for hyperphysectomy if planned. Okay, you provide the surgical intervention. You also provide pharmacological and non-pharmacological intervention for joint pain because they are always having joint pain. So you want to provide both. You want to give the prescribed drug as well as providing non-pharmacological, such as high application of heat and cold compression on the joint area that is being affected. You also want to provide emotional support to the client and family. You want to encourage the client and their family to express feeling related to body image as similar to the hypo case that we treated earlier. So hypophycectomy post-operative care. Recall, we say one of the management for hyperparathyroidism is hypophycectomy. That's surgical procedure. Okay, so what are our nurses' responsibilities? The first thing is we want to initiate post-operative care similar to craniotomy care. Craniotomy is the surgery that has to do with that of the brain. Okay, anything cranium that involves the skull or the brain. Okay, so you want to monitor vital signs, neurological status, and level of consciousness. You want to monitor vital signs, neurological status, and level of consciousness. You also want to elevate the head of the bed. It is very important. You elevate the head of the bed. You also want to monitor for increased intracranial pressure. How do we monitor for increased intracranial pressure? You want to ensure that patient is not having persistent headache. Any signs of persistent headache is as a result of increased intracranial pressure. You also want to ensure that patient is not vomiting, because these are the things you see when there is increased intracranial pressure. Patient will come down with persistent headache, vomiting, blue-red vision, changes in mental status, such as confusion or drowsiness. You see patients saying things off point. You should check their intracranial pressure. You also want to instruct the client to avoid sneezing, coughing, and blowing of the nose. Why are we asking them not to do this? Because in order not to increase the pressure, the moment they sneeze, okay, because there's a surgical procedure that is newly done, it could bring about tear. And when there is tear, what happens? There could be bleeding, and bleeding will lead to what? Shock. So we want to encourage that. We want to advise them to avoiding as much as possible sneezing, coughing, or blowing the nose. You also want to monitor for bleeding. Okay, you also want to monitor for and report signs of temporary diabetes insipidus by monitoring intake and output, and report excessive urine output. It is very important. Why? Because client is most likely going to have diabetic insipidus. Recall we said that it is this hypothalamus that gives control to every aspect of the endocrine glands. So you have to ensure that you monitor patients' fluid, the intake and the output. You have to strike a balance in order to ensure that patient is not overhydrated or underhydrated. You also want to, if the entire pituitary gland is removed, clients will require long life replacement of antidiuretic hormone, that's the ADH, That's if the entire pituitary gland is removed. You know, hypophyseectomy is just the removal of the pituitary gland. But if sometimes it's the portion, it could be the anterior or the posterior that is removed. But if it is the whole thing that is removed now, patients will have to be on a lifelong replacement of antidiuretic hormone, because we said that this hormone that controls the renal system is located where? In the pituitary. So you want to ensure that client is on long life replacement of antidiuretic hormone, as well as cortisol and thyroid hormones. We want to monitor and report for signs of infection and meningitis, such as checking the patient vital signs. If the temperature is increasing or the fluid coming out from the dressing is changing color, you want to ensure that you report and test that fluid for what? Infection. You also want to administer antibiotics, analgesics, and antipyrexia as prescribed. You want to administer oral mouth rinsers as prescribed. That is, you want to prevent, you know, when clients just have surgery, they are not to take anything per oral. So because their mouth is always dry at that process, and it helps to harbor bacteria. So you have to monitor it by providing oral care to the patient in order to avoid bacteria from developing, in order to prevent what? Infection and meningitis. So clients may be instructed to avoid using a toothbrush or brush teeth gently with ultra soft toothbrush for 10 days to 2 weeks after surgery. It is very vital to always tell clients that even if you want to brush, you have to use a very gentle brush, or you stay away from brush. You just water and just use water and this oral solutions that is being packed to Google the mouth and bring it out. But if they must brush, it has to be a soft toothbrush for 10 days to 2 weeks after surgery. You also instruct the client in the administration of prescribed medication. You instruct the client in the administration, you tell them how to take their drugs in order to prevent what? Relapse. Okay, so this is NCLEX tips. So following transphenoidal hypophyseectomy is just an example of the physectomy. That's the removal of the pituitary. It could either be total or subtotal. Okay, so following hypophyseectomy, monitor for and report post-nasal drip or clear nasal drainage, which might indicate a cerebrospinal fluid leak. Recall, we said that most times there is always an increase in intracranial pressure, and so we want to prevent the patient from sneezing, from coughing. Okay, so if eventually there's a drip or there's a drainage from the nasal cavity, and that nasal cavity is clear, the first thing you want to do is you want to test that fluid, because if it contains glucose, if you want to test that fluid for glucose, if that fluid contains glucose, then that fluid is definitely a cerebrospinal fluid. That means there is a leakage from that operation site. You want to take care of that. It is very important so that it does not become an emergency. But if the drainage is clear, if the drainage is clear from glucose, then that means it's fine. It's not cerebrospinal fluid. So our next topic is diabetic insipidus. Are we together, please?
Sure.
Okay, so our next topic is, I can hear myself back, I don't know. Okay, so our next topic is diabetic insipidus. So this is just an hyposecretion of antidiuretic hormone, that's ADH, by the posterior pituitary gland. Okay, and it's usually caused by, we've discussed anterior pituitary gland, and now we're talking about the posterior pituitary gland. So this is hyposecretion of antidiuretic hormone by the posterior pituitary gland, and it is caused by either stroke, trauma, surgery, or idiopathic. That means the cause is unknown, that you cannot pinpoint that this is what is causing it. Okay, So kidney tubules fails to reabsorb. This occurs as a result of the kidney tubules failing to reabsorb water. In central diabetes insipidus, there is a decreased antidiuretic hormone production. The function of this antidiuretic hormone is to help reabsorb water back into the system. Okay, so when there is low production of the antidiuretic hormone, what happens? You have excessive fluid going into the renal system, and the renal system just keep throwing them out of the body in form of urine. That's why you see the patient always having polyuria, always urinating, and the moment they're urinating, they're thirsty again. Why? Because there's a reduction of what? ADH, antidiuretic hormone. So basically, you have two types of diabetic insipidus. You have the central diabetic insipidus, and we have the nephrogenic diabetic insipidus. In central diabetic insipidus, there's a decreased ADH production. The major thing is for central, there's a decreased antidiuretic hormone. While for nephrogenic diabetic insipidus, the ADH production is adequate. Ideally, the ADH is adequately produced, but the kidney do not respond appropriately to the ADH. That means there's a nephron, there's a nerve miscommunication between the production of the ADH and that of the what? The kidney. Please let me recap this thing. For central diabetic insipidus, the ADH is not produced at the appropriate amount. That is, the amount that is being produced is low. There's hyperproduction. But for nephrogenic diabetic insipidus, the ADH is produced adequately, but there's a miscommunication between the nerves and the kidney. That's the major difference there. So what are the assessments, the clinical signs? The first thing is there is excretion of large amount of diluted urine. That's what? Polyuria. But this polyuria now is a diluted one. It's never concentrated. Okay, there's also polydipsia. There's polydipsia. There's dehydration. The polydipsia, that's excessive thirst. There's dehydration. That is how do you assess for dehydration? By checking the skin. The patient's skin is always dry and poor skin to go, dry membrane, you understand? So there's also inability to concentrate urine. There's inability to concentrate urine. There's also low inability to concentrate. There's also low urinary specific gravity. The urine gravity is always low. Patients could also come down with fatigue. Patients with this kind of disorder can come down with fatigue. There could be muscle pain and weakness. For diabetes insipidus, patients could also have headache. Patients is going to present with postural hypotension that may progress to vascular collapse without rehydration. There could also be tachycardia, of course. So what are the interventions? The first thing, you want to monitor vital signs. You monitor the vital signs. You monitor the neurological and the cardiovascular status of that patient. This is very vital. You also provide a safe environment, particularly for clients with postural hypotension. I think I overemphasize this aspect. For every NCLEX question, the first thing on our mind should always be safety. Safety, safety, and safety. Just put yourself in that situation that if I do this, will this client be safe? For every NCLEX question, please, let me give you a trick. For every NCLEX question, you should always ask yourself, is this safe if done? If it's medication, is this safe if administered? So for clients that is having postural hypertension, you cannot just leave the bed without the raise up. Patients can slide and fall down, and when they do, it's very dangerous. So you always want to ensure that the environment is safe. There's no water on the floor. Everything is dry so that you prevent slippery of the client. You ensure that their footwear is the one accepted by the hospital and by the NCLEX standard, so that they don't wear shoes that will pull them off their feet at any moment. So you always provide a safe environment, particularly for clients with postural hypotension. You also want to monitor electrolyte values for signs of dehydration. We talked about this, that anywhere there's sodium loss, there's always water loss, because sodium is a lover of what? Water. So anywhere you have dehydration, for this client, we said for diabetic insipidus, there is always going to be a sign of dehydration. We said it earlier. And for clients with dehydration, definitely this patient is going to have hyponatremia. We said what sodium are lovers of water. Anywhere water goes, sodium follow. So you have to ensure you monitor their electrolyte values for signs of dehydration. You also want to instruct the client to avoid fluid or liquids that produce diuresis. You also want to maintain intake of adequate fluid, that is IV, intravenous hypotonic saline, may be prescribed to replace urinary loss. You also want to monitor intake and output. You weight the patient and you check their specific or the urine osmolarity and specific gravity for excess urinary output. You also want to give vasopressin or desmopressin as prescribed. Yes, you want to give vasopressin or desmopressin as prescribed. These are used when the antidiuretic hormone deficiency is severe or chronic. These are one of the major medications for diabetic insipidus, depending on the severity. That's the vasopressin and desmopressin. You also want to instruct the client in the administration of medications as prescribed. That is, the desmopressin acetate may be administered by subcutaneous injection, intravenously, intradermally, or orally. We also want to watch out for signs of water intoxication indicating overtreatment. So when the client, watch out for signs of indication, water intoxication too. Instruct the client to wear a medic alert bracelet. This is very vital. It is very important to instruct the client to always wear their medic alert bracelet. It's like a chain, but it contains the client's information. I believe this should have been taught or will be taught under safety. Okay, so our next topic is syndrome of inappropriate antidiuretic hormone. That's SIADH. This condition it is a condition of hyperfunctioning of the posterior pituitary gland, in which excess ADH. Remember, for diabetic insipidus is a disorder of the posterior pituitary gland, and we said that the main focus there, or the main mechanism of action there, is that the ADH is not being produced appropriately, is underproduced. So syndrome of inappropriate antidiuretic hormone is an opposite condition for diabetic insipidus, because for NCLEX you have to cover a whole lot. So these are ways to kind of navigate it into our understanding. Like when you see one condition, you look for the opposite. Just an advice anyway. So syndrome of inappropriate antidiuretic hormone is just the hyperfunctioning of the pituitary gland, in which excess antidiuretic hormone is released, but not in response to body need. The body does not need the excess, but the posterior pituitary gland is malfunctioning by producing excess antidiuretic hormone. So what are the causes? Basically, causes include trauma. We have the same thing. We have trauma too. Trauma too can cause hypoproduction. You have it again causing hyperproduction. So causes include trauma, stroke, malignancy, often in the lungs or pancreas. That's cancer, which their origin is often in the lungs or pancreas. It could also be as a result of medication. Of course, when vasopressin and desmopressin is taken in excess, it can lead to syndrome of antidiuretic hormone, as well as stress. Stress has been found out to be a major cause of syndrome of antidiuretic hormone. So what are the So this syndrome results in increased intravascular volume. Of course, when you have excess intravascular, we talked about is an example of extracellular fluid. Okay, that's the fluid you find within the blood vessels. Okay, so it could also result in water intoxication. Of course, what we are running from in diabetic insipidus, that you have to monitor the vasopressin and the other drugs. So if not properly taken, or if not administered as prescribed, patient can come down with water intoxication. As well, there could be dilutional hyponatremia. It may also lead to cerebral edema, and the client is at risk for seizure. What are the assessments, clinical signs and symptoms? The first thing is there's always signs of fluid overload. Patient is always coming down with signs of overload. There's also changes in level of consciousness and mental status. Clients gain weight, they gain weight more than, we said, if you remember in our last class, we said the way the fluid in the body constitutes like 60% of human weight. So imagine someone with overproduction of antidiuretic hormone. That means the fluid that the kidney is supposed to excrete is being reabsorbed back into the system. There's an excessive reabsorption of the fluid by the kidney. Do you understand? Like the antidiuretic hormone. Antidiuretic hormone is okay, let me explain something. The function of antidiuretic hormone is to help fluid move into the renal tubules where they are being excreted, the fluids that are not needed by the body. But when the antidiuretic hormone is produced in excess, this fluid will not even go because there's a prevention of fluid moving to the kidney. So you have fluid back into the intravascular space, leading into what? Fluid volume excess. Okay, so clients will gain weight without edema. Edema might not be obvious, but you are going to see the client gain weight, increasing in weight every now and then. So there's going to be hypertension for diabetes insipidus because it's an underproduction. Patient is going to come down with hypotension. But for this client now, with the one with hyperproduction, patient is going to come down with hypertension. So it could also result in tachycardia, anorexia, nausea and vomiting, hypernatremia, low urine output. Of course, anywhere you find ADH, antidiuretic hormone, definitely the urine that we produce will be low. But anywhere you find low production of ADH, the urine that will be produced will be extremely high. And in most cases, for low urine output, this is always and always concentrated. Okay, so what are the interventions? You have to monitor the signs of cardiac and neurogenic. Sorry. Yeah, good. So monitor vital signs and including both cardiac and neurogenic status. Provide a safe environment, particularly for clients with changes in level of consciousness or mental status. This is similar to the care we provide for diabetic insipidus too. We want to monitor for signs of increased intracranial pressure and implement seizure precautions. You want to elevate the head of the bed a maximum of 10 degrees to promote venous return. You have to elevate the head of the bed. Let's take note of that. You also want to monitor intake and output, maintain daily weighing. You weigh the patient daily because we said patients gain weight excessively. You also want to monitor fluid and electrolyte balance. You want to monitor serum and urine osmolarity. You want to restrict fluid intake as prescribed for this client because they have fluid volume excess. Yes, you want to restrict their fluid intake as prescribed. You also want to administer IV fluid, usually the normal saline or hypertonic solution as prescribed. You should monitor the IV fluid carefully because of fluid volume overload. Now let's talk about the adrenal cortex problem. All we've been discussing so far has been the hypothalamus and the pituitary glands problem. Now let's talk about the adrenal cortex problem. You recall we said the adrenal glands are the ones we find directly on top of the renal, on top of the kidneys, and they are divided into two. So you have the renal cortex, which is the outer shell or the outer layer, and the inner cortex, and the adrenal medulla, that's the inner layer. Okay, so let's talk about the outer layer of the adrenal glands. Now the problems, what are the likelihood or what are the dysfunction that will happen? The first one is Addison disease. We have something known as the Addison disease. We also have something we call the Conn's syndrome, that's primary hyperaldosteronism. Okay, we also have Cushing's syndrome and Cushing disease. So for the adrenal medulla, the major disorder there is pheochromocytoma. Okay, so let's take this one after the other. The Addison disease is an example of the adrenal cortex disorder. So this refers to hyposecretion of adrenal gland. Okay, Addison disease refers to hyposecretion of adrenal cortex hormone. And earlier we said the adrenal cortex hormone include the glucocorticoids, mineralocorticoids, and androgen. Okay, and we said that these mineralocorticoids and the glucocorticoids are always what's it called? They're always produced in large amounts, unlike the androgen that is being naturally produced in minute or little amounts. So the Addison disease is an autoimmune destruction. It's an autoimmune destruction. Like it happens just on its own, autoimmune. Like you can't pinpoint that this is the reason. Like the immune system just start fighting itself. Okay, so it requires long life replacements of glucocorticoids. It requires long life replacement of glucocorticoids and possibly of mineralocorticoids if significant hyposecretions occur. Addison disease and Cushing's syndrome or Cushing disease are always, let me say at least 60 to 90%, always present in NCLEX question. Always present. The key thing there is to know which one is hypo and which one is hyper. It is very important because endocrine disorder are broad. Because they are broad, we have to keep the definition, like the disease to the name itself. So we don't mix it up when we get to the example. For Addison disease, it is low secretion of the glucocorticoids and mineralocorticoids hormone, low production. Because it is low, what happens? You cannot leave this patient to be on a low production for its life. It has to involve the patient using endogenous form of these hormones that has chosen not to produce in the body. And recall, we said the major cause is what? Is autoimmune. Like the normal cell just start behaving abnormally on its own in the body. So this condition is fatal. It's very fatal if left untreated. Addison disease is very dangerous if left untreated. So secondary adrenal insufficiency is caused by hyposecretion of ACTH. Recall, we said this is the primary production now. The primary cause, as in we said, the major cause is by what? Autoimmune destruction. That is, just starts on its own. Why the secondary adrenal insufficiency is caused by hyposecretion of adrenocorticotropic hormone from the anterior pituitary gland. Mineralocorticoid release is spare. Okay. So loss of glucocorticoids in Addison disease leads to decreased vascular tone. Loss of glucocorticoids in Addison disease lead to decreased vascular tone, decreased vascular response to catecholamines, epinephrine and non-epinephrine, and decreased glucogenesis. That's the breaking down of the glucose in the body. In Addison disease, loss of mineralocorticoids leads to dehydration, hypotension, hyponatremia, and hyperkalemia. So what are the assessments? What are the clinical signs? The first thing is muscle weakness. Why muscle weakness? Because we said there is what? Natremia, sodium is lost. Hyponatremia. Recall when we talked about electrolyte imbalances, we spoke about their function. We said basically one of the function is for sodium is muscle contraction. So anywhere you find muscle contraction, sodium being reduced, what happens? Automatically there will be muscle weakness because the electrolyte needed for contractibility of the muscle is impaired. Okay, so there could be muscle weakness. Patient will come down with loss of appetite and weight loss. When patients will have low blood pressure, there will be darkening of the skin. That is a hyperpigmentation for Addison disease, please. There's always salt craving. Patients with hypoproduction of patients with Addison disease are always craving salt. They love anything salty. So there is always gastrointestinal issues too. There could be mood changes such as irritability, depression, and difficulty concentrating. But mood changes too can occur, such as irritability, depression, difficulty concentrating, joint pain, dizziness, fainting, increased thirst and frequent urination, irregular menstrual period in women, decreased libido because of the androgen produced, loss of body hair, and hypoglycemia. They always have low blood sugar. So what are the interventions? You monitor vital signs, particularly for hypotension. You monitor weight, monitor patient's weight. You monitor intake and output. You monitor white blood cell counts because they are prone to infection. You also want to monitor blood glucose, potassium, calcium, and sodium level. You have to administer glucocorticoids and or mineralocorticoid medication as prescribed. You want to observe for Addison crisis caused by stress, infection, trauma, or surgery. Because this patient is not producing enough glucocorticoids and mineralocorticoids. We said these are necessary for metabolism of fat, protein, and fat, and carbohydrates. So when this hormone is not produced, what happens? The body will not be able to metabolize it. Hence, the tissues and the cells will be deprived of this needed energy in form of ATP. So patient is likely to come down with what? Infection. They will lose weight because the energy is not available for the cells, of course. And because patients will have to be on glucocorticoids or glucocorticoids and mineralocorticoids for a long time of period, for a lifetime. You have to observe them for Addison crisis caused by stress, because even stress, infection, trauma, or surgery can further crush the adrenal gland in order not to even produce at all. You know, Addison diseases, they are still producing, but in a smaller amount. But if they are too stressed, or there is infection or trauma or even surgery, patient might not even produce it at all, hence leading to Addisonian crisis. So what are client education? You have to educate these clients, because clients will need to be on long life, like they have to be on this drug all through their life. So you need to educate them for the need for long life glucocorticoid replacement and possibly lifelong mineralocorticoid replacement. Corticosteroid replacement will need to be increased during time of stress. Recall, I said that during stress, surgery, infection, or trauma, the Addison disease, the glucocorticosteroid that is being produced in low quantity might not even be produced anymore because of the infection has overwhelmed the adrenal gland. So you want to educate them that when they have infection, or when they are susceptible to infection, or when they undergo stress, or when they are traumatized, they should speak to their primary health care provider so that they can increase their dose of glucocorticosteroid. This is very essential. You also tell them to avoid stressful exercise or strenuous exercises and stressful situations. They should avoid over-the-counter medication, yes, because most of this medication interact with the glucocorticosteroid that are prescribed to them. We want to advise them that for any drugs they are taking, they should always communicate with their primary healthcare provider for proper prescription. Diet should be high in protein. Recall, we say glucocorticosteroids and mineralocorticosteroids are the one responsible for the metabolism of fat, protein, and carbohydrates. So when they are not being produced, what happens? all the food we're eating will just be waste to the body because the body is not metabolizing them. So you have to encourage them to eat food that are high in protein so that their chances of being metabolized. So client taking glucocorticosteroids should be prescribed calcium and vitamin D supplements to maintain normal level and to protect against corticosteroid-induced osteoporosis. Of course, the use of corticosteroid kind of thin out the bone. They thin out the layers of the bone. So when clients are on it, they should have enough intake of calcium and vitamin D in order to help what? Strengthen the bone to prevent osteoporosis. Patients will also wear their medic lab bracelet. It is very vital. Now, what is Addisonian crisis? It's a life-threatening disorder caused by acute adrenal insufficiency. Acute, it just happened all of a sudden. And it is precipitated by stress, I've explained this, infection, surgery, or abrupt or sudden withdrawal of exogenous corticosteroid use. Recall, we said for Addison disease, patients will have to be on a lifelong medication, such as the glucocorticoids. So when patients just decide to stop it, it can lead to Addisonian crisis. They should not at any time stop their drugs except if they are at risk for hyper that we'll be discussing. That's the Cushing's syndrome or Cushing's disease that we'll be discussing later. Except that, and that should be under prescription. On no account should they stop their drugs. So they should be educated, they should be advised, they should be instructed on what to do. So it can also cause hyponatremia. This Addisonian crisis can cause hyponatremia, hyperkalemia, hypoglycemic, and even shock. What are the assessments? Clinical manifestation. Patients always come down with severe headache. Patients with Addisonian crisis always come down with severe headache. They always have severe abdominal, leg, and lower back pain. Recall, everything here is like severe because it's an advanced stage of what? Addisonian crisis is an advanced stage of what? Addison disease. Please, let's keep that in mind. Questions are always in that direction. So you also the patients could also come down with generalized weakness. They're always tired. Why? They will be tired because there's no glucose moving into their tissues and cells. So patients will be tired. There will be irritability and confusion. They are highly irritable. And they have severe hypotension, which could lead to shock. Intervention, what do we do? He prepares to administer glucocorticoids intravenously as prescribed. Unlike Addison crisis, patient can still take oral. But for Addison disease, patient can still take oral. But for Addison crisis, it's an emergency. Patient will have to take the glucocorticosteroid intravenously. You also want to administer IV fluid as prescribed to replace fluid loss and restore electrolyte balance. You also want to follow resolution of the crisis, like if you have to administer glucocorticosteroid and mineralocorticoid orally as prescribed. So after it has resolved, after the crisis has resolved, patients can go back to taking their oral prescribed glucocorticoid or mineralocorticoid. You also want to monitor vital signs, particularly blood pressure. You want to monitor urine intake, we want to monitor fluid intake and output. We want to monitor the lab values, particularly sodium, potassium, and blood glucose level. We want to protect the clients from infection. They are highly prone to infection. We also want to maintain bed rest and provide a quiet environment. What are the NCLEX tips here? Client taking exogenous corticosteroid must establish a plan with their primary healthcare provider, that's PHCP, or endocrinologist for increasing their corticosteroid during time of stress, infection, trauma, or surgery. Are we together, please? Hello, are we together?
Yes, we are
Yes.
together.
Oh, okay. So now let's take Cushing disease. If you have been following since, you see that when I take one condition that is hypo, I support it with an hyper condition. I support it with another condition that will be hyper, that will be opposite. So please, let's read in that line for easy understanding and assimilation. Because for NCLEX, they will always test your hyper knowledge and your hypo knowledge of these diseases. So the next thing is Cushing disease. Cushing disease is a metabolic disorder characterized by abnormally increased secretion of cortisol. Abnormally increased secretion of cortisol. It is caused by increased amount of AC. It is caused by increased amount of ACTH. We've been talking about ACTH since. Okay, so it is caused by an abnormal increase of ACTH, which means adenocorticotropic hormone here secreted by the pituitary gland. So what is Cushing syndrome now? It is a metabolic disorder resulting from chronic and excessive production of cortisol by adrenal cortex or from the administration of glucocorticoid in large dose for several weeks or longer. Okay, so this is just like opposite of the Addison disease that we've been talking about. Yes, so what are the signs of Cushing syndrome? You see, they're always like this. There is always personality change. There's hyperglycemia because there's an overproduction of the cortisol. Unlike what we have in Addison disease, there is a low production, right? So the patient is always having moon face. Moon face is the cheek is always big, round, and sometimes shiny. Okay, there's always CNS, that's central nervous system irritability. There's susceptibility to infection. And there is sodium fluid retention. Patient is retaining fluid and sodium. For males, we have gynecomastia, that is, they have this breast. Their mammary gland is enlarged like that of female. There's always fat deposition on the back. You see them having their backside being fatty, and even their abdominal region. Okay, so there is for female, there is amenorrhea, that is lack of menstruation or cessation of menstruation. There is also hirsutism, that is excessive hair in female. There is a pubic striae, that's a stretch mark. Okay, it could also lead to osteoporosis as well as petechiae. What are the interventions? You monitor for signs, monitor vital signs, particularly blood pressure, monitor intake and output, and weigh declines. You also want to monitor blood laboratory values, particularly the white blood cells and the serum glucose, sodium, potassium, and calcium level. Prepare patients for radiation if possible. Or prepare the patient for radiation if the condition results from pituitary adenoma. That is, if the condition is caused by cancer. So you also want to administer chemotherapy as prescribed for inoperable adrenal tumor. That is, if it is caused by tumor, chemotherapy too is allowed. You also want to prepare the client for removal of pituitary tumor. Of course, you want to prepare the client for removal of the pituitary tumor, which is usually done surgically, and the procedure is known as hypophysectomy. We talked about it earlier. They can also do sublabial transphenodial adenectomy, okay, if the condition results from increased pituitary secretion of ACHT. Okay, so you want to prepare the client for adenectomy if the condition results from an adrenal adenoma. Okay, so glucocorticoid replacement may be required following adenectomy, of course, because the adrenal gland that is producing the glucocorticosteroid is being taken away surgically, it's being removed. So you have to put something in replacement, which is usually administration of glucocorticosteroid, okay? So the client required a long life glucocorticoid replacement following adrenectomy should obtain instruction from their primary healthcare provider about increasing their glucocorticoids during time of stress. This point is very important. For every client who has cortisone, such as the glucocorticoid and the mineralocorticoids, they should always communicate with their healthcare provider before altering their prescription. They should never alter their prescription on their own. They should discuss with the primary care provider. So you want to assess patients and protect against post-operative thrombus formation, because Cushing's syndrome predisposes to thromboembolism. Allow the client to discuss feelings related to body appearance. Instruct the client about the need to wear medic alert bracelets. For all conditions in endocrine, they should always wear their medic alert bracelet. That will help in proper management, and as well tell anyone if there's an emergency, it can help guide the rescuer on what to do and how to help the clients. So what are the NCLEX tips here? Addison disease is characterized by hyposecretion of adrenal cortex. This is just the logic. Addison disease, underproduction of adrenal hormones, while Cushing syndrome and Cushing disease are characterized by hyposecretion of the adrenal cortex hormone. That is just the basic for these two disease condition. One is hypo, one is hyper. But let me put it to you that Addison disease can lead to Cushing disease. If a patient is having Addison disease and the client is on glucocorticoids for a long period of time, the adrenal gland can begin to malfunction. Patient can come down with Cushing syndrome. And if Cushing syndrome is overmanaged, like there is overmanagement, such as not overmanagement per se, excuse me, like if managed properly, can still lead to hypoproduction. Take for instance the adrenalectomy that we talked about. If the adrenal glands, all the adrenal gland has been removed, what happens? There's no way patient will produce this cortex hormone, that's the adrenal hormone, that's the glucocorticoid. What happens? There will be no production. That patient is still going back to adrenal disease. So depending on the modality of treatment, a client with Addison disease can actually come down with Cushing syndrome, while a client with Cushing syndrome, if undergo surgical removal of the adrenal tumor, can lead to what? Addison disease. That's the logic there. So the next thing is Cushing's disease. Cushing's disease is hypersecretion of mineralocorticoids from adrenal cortex of the adrenal gland. All we'll be talking about since both the both the Addison disease and the Cushing disease had to do with glucocorticoids abnormality, either hypo or hyper. Hypo for adrenal Addison disease, hyper for Crohn's for Cushing disease. But for Crohn's disease, basically, it has to do with hypersecretion of mineralocorticoids from the adrenal cortex, most commonly caused by adenoma, that's cancer of the adrenal gland. Excessive secretion of aldosterone causes sodium and water retention and potassium secretion, leading to hypertension and hypokalemic acidosis. What are the clinical manifestations? The first thing is the symptoms are always related to that of the hypokalemia. When we talked about hypokalemia, anyway, any client, okay, there's a relationship. A single client can come down with all the, if not all, most of the electrolyte imbalances. A patient can have hypokalemia, can have hypernatremia, can have hypocalcemia, they just come down that all their electrolytes are just abnormal. So, but there's a relationship between hypokalemia and hypernatremia. Anyway, you find hypokalemia, most likely that patient is going to have hypernatremia. And if a patient have hyponatremia, most likely he or she is going to have hyperkalemia. There's an opposite relationship between hypokalemia, between potassium and sodium. So anyway, you find hypocalcemia, you're going to find natremia, okay? So your patient is likely going to come down with headache, fatigue, muscle weakness. Patients will also present with cardiac dysrhythmias. There could also be paresthesia, tetany. There could also be visual changes, glucose intolerance, elevated serum aldosterone levels. Interventions. The first thing is monitor vital signs, particularly blood pressure. You monitor potassium and sodium level. Monitor intake and urine output for specific gravity. Monitor for hyperkalemia, particularly for clients with impaired renal function or excessive potassium intake. You also want to administer potassium supplement as prescribed to treat hypokalemia. You also want to prepare the clients for adrenectomy. Of course, there's an hyposecretion and it's usually caused by tumor. That's the Crohn's disease. So you want to prepare these clients for adrenectomy. Also, you also want to maintain sodium restriction. You recall, we said that this client is having hypokalemia, hypernatremia as one of the signs, hypernatremia. So you want to prevent, so you want to reduce their sodium intake, okay? Maintain sodium restriction if prescribed preoperatively, okay? You also want to administer glucocorticoids preoperatively as prescribed to prevent adrenal hypofunction and prepare for stress for the surgery. You also want to monitor the clients for adrenal insufficiency. To monitor them for insufficiency post-operatively. You also want to instruct the client regarding the need for corticosteroid therapy following adrenectomy. You also want to instruct the client about the need to wear their medical alert bracelets. It's very vital. So our next topic is pheochromocytoma. Pheochromocytoma. This is a catecholamide producing tumor. It's just a tumor. The tumor then makes it a tumor, usually found on the adrenal gland. This is an example of adrenal medulla dysfunction. Under our adrenal gland, let's have a quick recap. We said the adrenal gland is divided into two layers. You have the adrenal cortex and you have the adrenal medulla. Part of the adrenal cortex, we've been talking about the disorder, we've been talking about the Addison disease, the Cushing's disease and Cushing syndrome, Addison crisis, the Crohn's disease. But now we're talking about the medulla part, the adrenal medulla, which is the inner part of the adrenal gland. So one of the dysfunction there is pheochromocytoma. Yeah, I had this question in my NCLEX. During my NCLEX, I had a question on this. So this is a catecholamide producing tumor. It's a tumor usually found in the adrenal medulla. So extra-adrenal location, although it's found outside, so sometimes, which other part of the body, such as the chest, the bladder, the abdomen, the brain, typically it is benign tumor. That is, it is restricted to that location. Benign, it cannot metastasize, but can be malignant. Okay, sometimes it's not disturbing, but sometimes it could become a malignancy. That is, it can become a cancerous. That's what it is. Benign simply means it can just be at its own place, okay? So excessive amount of epinephrine and non-epinephrine are secreted. When this condition occurs, there's always an abnormal production, which is usually in an excessive form of epinephrine and non-epinephrine. So diagnostic tests include a 24-hour urine collection of VMA. The VMA there is found in the urine, okay? So there is also surgical removal. There could be surgical removal of the adrenal gland, which is usually the primary treatment because it's a tumor. So the next thing is just to remove it. So symptomatically, treatment is initiated if surgical removal is not possible, please. If surgical removal is not possible, then you can treat the patient based on their symptoms. Complications, sorry. Complication may lead to crisis, okay? Hypertensive retinopathy, and there could also be hypertensive neuropathy and nephropathy. There could be cardiac enlargement and dysrhythmias. There could be heart failure, myocardial infarction, increased platelet aggregation, as well as stroke. So what are the assessments? There's paroxysmal and sustained hypertension. Patient is always having hypertension. Patient might not even be a known hypertensive patient, but with this disease, because there is an increased production of epinephrine and non-epinephrine. We record that for our unstable client, especially client that is having low, very low blood pressure. Take for example, patient at their last phase of life, okay, we give epinephrine and non-epinephrine. This is just to help to sustain their blood pressure. So because this one is produced in excess amounts for this condition that we're talking about, and that's pheochromocytoma. There's always an aggressive or excessive amount of epinephrine. Hence, patient is always coming down with high blood pressure. So there's always severe headache, tremor. Patient could also have tremor. There could also be palpitation, pain in the chest or abdomen, because we said that this tumor can also be found in the chest or in the abdominal area. So there could also be flushing or perfuse diaphoresis, that is, patient is always sweating. Patients could also be heat intolerance. Patients will come down with hyperglycemia, weight loss, nausea, and vomiting. What are the interventions? We monitor vital signs, particularly blood pressure and heart rate. Monitor for hypertensive crisis. We monitor for complications that could occur with hypertensive crisis, such as stroke, cardiac dysrhythmias, and myocardial infarction. Ensure the client not to smoke or drink caffeinated drink, any drink that contains caffeine, or change positions suddenly. Why? Because this has been found out that caffeine tends to increase the blood pressure. You also want to prepare, because patient is always having high BP, so you don't want to add to their blood pressure. So you also want to prepare to administer alpha adrenergic blocking agents and beta adrenergic blocking agents as prescribed to control hypertension. We'll be talking about these agents under their medication, because we'll be taking their medications tomorrow. So you also want to monitor serum glucose level, because client is prone to abnormal glucose level. So you also want to promote bed rest and non-stressful environment. We provide high diet in form of calories, vitamins, and minerals. Prepare clients for adenectomy, that's surgical removal. So the next one is hypothyroidism. Hypothyroidism is a state resulting from hypoproduction of thyroid hormone. Hypothyroidism, let's divide it into two. Hypo one place, low reduction. Thyroid one place, from thyroid gland. So that simply means low production of the thyroid hormones. And they are characterized by a decreased rate of body metabolism. So the thyroid are responsible for metabolism too. So when there's low production, what happens? The rate at which the body metabolizes everything we eat is being what? Is being reduced. So the T4 is low, and the TSH is elevated. In primary hypothyroidism, the source of dysfunctioning is the thyroid gland. So we have two types of hypothyroidism. We have the primary hypothyroidism and the secondary hypothyroidism. For primary hypothyroidism, the source of dysfunction, that is the source of lowering of the thyroid hormone, is by the thyroid gland. While for secondary hypothyroidism, the thyroid is not being stimulated by the pituitary to produce at all. That means if there is no production at all. So what are the assessments? The first thing is tiredness. Patient will be tired because metabolism is not going on, and glucose are not being broken down to ATP that the body can make use of. So patient is more sensitive to cold. There could be constipation, there could be dry skin, weight gain, okay? There could be puffy face, hoarse voice, fuzzy hair, and skin. There could also be muscle weakness, muscle ache, tenderness and stiffness, menstrual cycles that are heavier than usual or irregular. There could be thinning of the hair. There could be slowed heart rate, also called bradycardia. There could also be depression or memory loss. What are the interventions? You monitor vital signs, including heart rate and rhythm. You administer thyroid replacements, that's levothyroxine sodium is commonly prescribed. Levothyroxine is commonly prescribed. You also want to instruct the client about thyroid replacement therapy and about the clinical manifestation of both hypothyroidism and hyperthyroidism. You instruct the client So are we together? Are we together, please? Are we together?
Yes.
Oh, okay. So you want to instruct the client in a low calorie, low cholesterol, low saturated fat, discuss a daily exercise program, such as walking. You also want to assess the client for constipation, provide roughages and fluid to prevent constipation, provide a warm environment for the client because client is intolerant to cold. So you have to ensure their environment is warm. Avoid sedative and opioid analgesics. You should educate the client on the importance of avoiding sedative and opioids analgesic. Why? Because this can help to further slow down the rate of respiration. And we said these clients are prone to low respiratory rate, that's bradycardia, bradypnea. So you want to ensure that. And the analgesic too, you are preventing them from constipation because they are prone to constipation. Assess client for constipation. So you also want to ensure that you don't give them things that will constipate them. And opioid has been found out to increase constipation. So you want to monitor for overdose of thyroid medication. They should always be monitored if on medication. So you instruct the client to report episode of chest pain or other signs of overdose immediately. So the next one is myxedema coma. This is a complication actually. Myxedema coma is rare but serious disorder resulting from persistently low thyroid production. Please, let's now relate this myxedema to Addisonian crisis. You know, Addisonian crisis is like a severe condition or a severe form of Addison disease. So this myxedema comani is an impaired or severe form of hypothyroidism. Let's take note of that when we're writing. It's a severe form of it, okay? So we don't get it confused. It's a rare but serious disorder resulting from persistently low thyroid production. Coma can be precipitated, that is a myxedema coma, can be precipitated by acute illness, rapid withdrawal of thyroid medication. This is similar to Addisonian crisis, if you remember. Anesthesia and surgery, hypothermia, or the use of sedative and opioids. That's why we said sedative and opioids should be avoided in hypothyroidism. It should not be used. What are the clinical signs? The first thing is hypotension, bradycardia, hypothermia, hyponatremia, hypoglycemia, general edema, respiratory failure, eventually coma. Intervention: maintain a patent airway because their respiratory rate is low. You want to maintain the patent so your patient can have adequate ventilation. You also institute aspiration precaution, ensure that the patient is free from aspiration and put things in place if eventually aspiration occurs. You want to administer IV fluids, which could either be normal or hypotonic saline as prescribed. You also want to give levothyroxine. Besides, it's a major drug used in hypothyroidism intravenously. It has to be intravenously and not oral. Why? Because this is a crisis. This is a severe form of hypothyroidism. You also want to administer glucose intravenously as prescribed. Administer corticosteroid as prescribed. Assess the client's temperature hourly. It's very important because they are at risk of hypothermia. You also want to monitor blood pressure frequently. You keep the client warm, monitor for changes in mental status, monitor electrolyte and glucose level. So what is hyperthyroidism now? Hyperthyroidism results from hypersecretion of thyroid hormone. That's the T3 and the T4. It is usually characterized by an increased rate of body metabolism. It's just an opposite of hypothyroidism. Recall, I did not bring it immediately after hypothyroidism. I brought this coma, myxedema coma, after hypothyroidism because it is a severe form of hypothyroidism. Okay, so hyperthyroidism now results from hypersecretion of thyroid hormone, and it is usually characterized by increased rates of body metabolism. For hyperthyroidism, there's reduced rate of metabolism, but for hyperthyroidism, the rate at which the body breaks down the glucose, the protein, the this, the that, into ATP that the body needs for energy is at a faster rate than the body can match up with. So what are the common causes? The common cause is the Graves' disease, also known as toxic diffuse goiter. Graves' disease, also known as toxic diffuse goiter. It's one of the major causes of hyperthyroidism. Clinical manifestations are referred to as thyrotoxicosis. So we can categorically say that hyperthyroidism equal to thyrotoxicosis is the same thing. So the T3 and the T4 are usually elevated and the TSH level is low. I need a moment, please. I'll be right back. Okay, so hyperthyroidism. So clinical, okay, I said that it is always the same thing. Hyperthyroidism is equal to adrenotoxicosis. Sorry, thyrotoxicosis. I'm so sorry. So what are the assessments? Clinical manifestation. The first thing is nervousness. Patient is always nervous, anxiety, irritability. There could be mood swing, difficulty sleeping, persistent tiredness and weakness. There could be sensitivity to heat, palpitation, swelling in the neck from an enlarged thyroid gland, which is goiter. It's very obvious. And there's switching or trembling. Patients could also come down with weight loss. So this is an example. This is a major clinical sign. This is one of the things we see with clients with goiter. Okay. When you see, we said goiter is a major cause of hyperthyroidism. So this is a clinical sign of what? Hyperthyroidism patients. The goiter aspect is not clear here. The neck, there is always a swollen neck. The neck too is always swollen, but this is a clinical sign. This sign, that is the protrusion of the eye now, is known as exophthalmos. Yes, exophthalmos. This is a major clinical sign for hyperthyroidism. Like, this is just there. You see the patient eye protruding very big, like protruding almost out of their eye socket. So this is one of the clinical signs. Watch out for this in questions. The moment you see exophthalmos, okay, exophthalmos is just a protrusion, which is the major clinical sign for hyperthyroidism. So interventions, you provide adequate rest, administer sedative as prescribed because they are agitated, they are restless. So you want to calm their nerves by giving the prescribed sedative. You also provide a cool and quiet environment because they get irritated easily with noise. So you want to ensure that the environment is usually quiet. You also want to obtain their weight daily. You want to provide a high-calorie diet, and you want to avoid the administration of stimulants. Stimulant and endocrine system disorder is a no, no, no. So administer antithyroid medications such as metimazole or propyltiuracil. Metilmazole or propyltiuracil. You also want to administer iodine preparations that inhibit the release of thyroid hormones as prescribed. You also want to administer propranolol for tachycardia as prescribed. Prepare the client for radioactive iodine therapy as prescribed to destroy the thyroid cells. So prepare the client for subtotal thyroidectomy if prescribed. Elevate the head of the bed. If client is experiencing exophthalmos, if client is exhibiting exophthalmos, which is the bulging of the eyeballs, you should elevate the head of the bed. In addition, instruct on low salt diet. And we also have to administer artificial tears because their eyeballs are protruded. They are at risk of what? Eye dryness. Their eyes are always dry. So in that case, we should always provide them with artificial tear because the eyeballs need those liquid in order to perform some of their functions. So I also want to encourage the use of dark glasses and tape eyelid close at night if necessary. You also want to allow the client to express concerns about body image and changes. What is thyroid storm? This is an acute and life-threatening condition occur in clients with uncontrollable hyperthyroidism. When a client is having hyperthyroidism at an uncontrollable rate, it becomes a storm. It can be caused by manipulation of the thyroid gland during surgery and the release of thyroid hormone into the bloodstream. It can also occur from severe infection and stress. What are the clinical manifestations? The first one here is fever, tachycardia, systolic hypertension, nausea, vomiting and diarrhea, agitation, tremors, anxiety, irritability. Their symptom is similar to hyperthyroidism because it's just an extension. If the hyperthyroidism is not managed, then it can lead to thyroid storm. So patient could also have delirium or coma. So what are the interventions? Maintain a patent airway and adequate ventilation. Administer antithyroid medications, iodines, propranolol, and glucocorticoids as prescribed. You also want to monitor vital signs and cardiac dysrhythmias. You want to administer non-salicylate antipyretic as prescribed because salicylate has been found out increase free thyroid hormone level. So any drug you are giving them should not contain salicylic acid. It should just be pure antipyretic for their temperature of pain. Okay, you also want to use a cooling blanket to decrease temperature because temperature is always high. You should decrease the temperature by applying a cool blanket, and recall no give of salicylate antipyretic. You should give pyretic that does not contain salicylic acid. In this case, you cannot give aspirin because aspirin contains salicylate. Okay. Thank you very much. We have come to the end of this class for the first volume. It's actually in 2 forms. You have the second one at by tomorrow. Yes, tomorrow, God's willing. We have the second subclass where we'll be taking the medications used for adrenal gland disorders. Questions, please. Questions? Hello? Are we together?
Yes, we are together.
Do we have questions, contributions? Okay, do we have questions, clarification, contribution, addition, or subtraction?
So far, no questions. We thank you for the presentation. Just maybe questions we come tomorrow, maybe. But so far, so good.
Okay. I hope I've been able to pass one or two things, and I hope it will guide in our studies.
Yeah, sure.
NCLEX is doable. You can do it.
Okay.
Yeah,
Yeah, we hope so, and we shall do our best.
of course.
Yeah, sure. Thank you very much.
You're most welcome. So I think we can
welcome.
sleep a night here.
Yeah, sure. A good night as well.
All right, good night.
Yeah, bye.
Bye.